Hello, everyone, and welcome to today's live broadcast, The Pharmacogenomics Behind the Investigational Treatments of COVID-19 and Its High-Risk Underlying Conditions. I'm Christy Jewell of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is brought to you by LabRoots and sponsored by Admera Health. For more information on our sponsor, please visit admerahealth.com. Now let's get started. I would like to remind everyone that today's event is interactive, and we encourage you to participate by submitting as many questions as you want at any time you want during the presentation. To do so, simply type them into the Ask a Question box and click Send. We will answer as many of your questions as we have time for at the end of the presentation. If you have trouble seeing or hearing the presentation, click on the Support tab found at the top right of your presentation window, or you can use that Ask a Question box to let us know you're experiencing a problem. Today's presentation is educational and thus offers continuing education credits. Please click on the Continuing Education Credits tab located at the top right of your presentation window and follow the process to obtain your credits. I would now like to introduce today's presenter, Dr. Becky Winslow, Senior Clinical Pharmacogenomics Specialist, Medical Affairs Department at Admera Health. For a complete biography on Dr. Winslow, please visit the Biography tab at the top of your screen. Welcome, Dr. Winslow. You may now begin your presentation.
Hello, and thank you for joining me today for our webinar on the pharmacogenomics behind the investigational treatments of COVID-19 and its high-risk underlying conditions. My name is Dr. Becky Winslow. I'm the Senior Clinical Pharmacogenomics Specialist in the Medical Affairs Department at Admera Health. At the conclusion of this webinar, I hope that you are able to describe how pharmacogenomics-directed medication therapy management before exposure to COVID-19 has the potential to reduce the chances of patients with chronic disease experiencing severe or fatal COVID-19 infection outcomes, and also to be able to describe how pharmacogenomics-directed medication management has the potential to improve the efficacy and decrease the toxicity for medications used to treat COVID-19 and its sequelae. Let's get started by looking at the prevalence and the epidemiology for COVID-19 in the United States. As of April the 21st, 2020, there have been over 800,000 total cases of COVID-19. Out of that number, there have been almost 45,000 total deaths. COVID-19 has affected patients in all 50 states and its territories. For hospitalized patients in the U.S., according to the CDC, the highest rates of COVID infection have occurred in adults that are aged greater than 65 years old. As we would expect, the most common pre-existing conditions in these patients are diabetes, chronic lung disease, cardiovascular disease, and those patients that are immunocompromised. So let's take a look at the pre-existing conditions as well as the medications used to treat those pre-existing conditions and the pharmacogenomics behind them. As I mentioned previously, diabetes, which includes hyperglycemia and insulin resistance, cardiovascular disease such as hypertension or congestive heart failure, chronic lung disease such as asthma or COPD. Needless to say, precisely managing these conditions best prepares a patient for exposure to COVID-19, and should the patient become infected with COVID-19, they may experience better outcomes the healthier they are. So let's look at the pharmacogenomic gene-drug pairs that are included on Admera Health's PGX1 Plus test. For cardiovascular disease, we have a cardiology section. Medications that are frequently used to treat the cardiovascular diseases that we've suggested are included in this section. We also have an endocrinology section. The medications in this section of the test are used to treat diabetes. And lastly, we have a pulmonary section. The medications in this section of our test include the drugs and genes that are used to treat asthma, COPD, and cystic fibrosis. Again, precisely managing these medications using the patient's pharmacogenomics data may help mitigate COVID-19 outcomes. So let's take a minute to look at the immunocompromising conditions that can predispose a patient to COVID-19 infection should they be exposed to COVID-19. These conditions include cancer, infectious diseases such as HIV, tuberculosis, and hepatitis, and also autoimmune diseases such as lupus, rheumatoid arthritis, and psoriasis. In addition to these conditions predisposing a patient to an increased risk of COVID-19 infection, some of the medications that are consumed by these patients can actually increase their compromise and make them less able to fight off COVID-19. So let's look at the pharmacogenomic gene-drug pairs that are included on the PGX1 Plus test by Admera Health. For cancer, we have oncology medications. As you can see here, we have some of the most commonly used cancer medications, including cisplatin, fluorouracil, tacrolimus. We also have infectious disease section. In this section, we have the genes and drugs that are used to treat the infectious diseases I mentioned previously, such as HIV and hepatitis. Lastly, we have a rheumatology section on the PGX1 Plus test. As I mentioned earlier, some patients may actually take medications that can reduce their immunity and set them up for COVID-19. The medications in this category are included here in the rheumatology section, and they include methotrexate, Humira, Merrill, and Remicade. Again, by precisely managing a patient's medications, using their pharmacogenomic data can help set the person up to be resistant to COVID-19 infection, and should the patient become infected with COVID-19, they will be healthier so they can fight the disease. We're now going to discuss the pathophysiology of COVID-19. We're going to look at how the human body responds through the immune system. And we're also going to take a look at medications and their pharmacogenetics that are being considered for use in the treatment of COVID-19 in either the pathophysiology, the human response, or the acute clinical course that results from COVID-19 infection. The image that I'm showing you here is a picture of the inside of an alveoli within the lung. You can see the alveolus and the host cell division. COVID-19 is similar to other viruses in that it binds to a specific receptor on the host cell membrane so that it may enter the host cell to replicate. In the case of COVID-19, it binds to the ACE2 receptor. If you see in this picture, that interaction is enhanced by TMPRSS2. Keep that in mind because we're going to look at that a little bit closer on the next slide. The next step in the pathophysiology of COVID-19 is the viral membrane fusion and endocytosis. As I mentioned earlier, COVID-19 is similar to other viruses in that it then uncoats, it releases its RNA into the host cell, it replicates itself, it restructures itself, and then it exits the cell through exocytosis. There are several medications that are under investigation that target the steps in the COVID-19 pathophysiology. You can see them now on the screen at the place of their action within the COVID-19 pathophysiology pathway. We're now going to look at some of these medications up close and in more detail. We're first going to look at the investigational anti-COVID-19 medications. And I want to point out here that the reason that we call them investigational anti-COVID-19 medications is that many of these medications are actually approved for other indications for use in the U.S. by the FDA. However, in the treatment of COVID-19, there are no FDA-approved medications. The medications that we are investigating are simply being repurposed for the use in COVID-19. So let's look at TMPRSS2 inhibitors. If you recall from our previous slide on the pathophysiology of COVID-19, TMPRSS2 facilitates the binding of the SARS virus, COVID-19, to the ACE2 receptor. One of the medications that is most studied as a TMPRSS2 inhibitor is canostat mesylate. This medication is not available in the U.S., but again, it is being considered in clinical trials. Secondly, we have the medications hydroxychloroquine and chloroquine. You've probably heard a lot about these medications in the media. They mitigate COVID-19 pathophysiology by inhibiting the viral entry and inhibiting endocytosis of the viral content into the cell. These medications are also thought to have an immunomodulatory effect within the host. Lastly, we have Arbidol. Arbidol is a viral membrane fusion inhibitor. It works to inhibit the ACE2 and S protein binding to prevent viral entry. The net effect of these medications is that they decrease COVID-19 virility. This group of medications are also investigational anti-COVID-19 medications. You may recognize these medications for their use in other viruses in the U.S. The first group are the viral protease inhibitors, which include lopinavir, ritonavir, and atazanavir. The second group are the RNA-dependent RNA polymerase inhibitors, such as ribavirin, remdesivir. Again, some of these medications are approved for use in the U.S. Some are within clinical trials being studied, and some are awaiting FDA approval. Their net effect is to decrease COVID-19's virality so that it cannot replicate. This last group of investigational anti-COVID-19 medications work a bit differently, and some of them are controversial for use as anti-COVID-19 medications. The first group are the angiotensin receptor blockers, including losartan and valsartan. These medications bind to the ACE2 receptor, and they block COVID-19 from binding to the ACE2 receptor. Angiotensin converting enzyme inhibitors decrease the conversion of angiotensin 1 to angiotensin 2, and therefore they reduce vasoconstriction and its sequelae, which contribute to the poor outcomes for COVID-19 patients. One school of thought about these medications is that, in fact, they may be negative or they may cause harm in the treatment of COVID-19. The school of thought is that angiotensin receptor blockers and ACE inhibitors may actually cause upregulation of the ACE receptors and therefore provide more binding sites for the COVID-19 virus to enter into the host cell and replicate. The last group of investigational anti-COVID-19 medications are the anti-androgens, such as spironolactone and flutamide. These medications actually end up acting like CMPR-SS2 inhibitors because they disrupt the androgen pathway. That is how they mitigate COVID-19 pathophysiology. So let's take a look at the pharmacogenetic drug dreampairs for the miscellaneous therapeutic classes of medication that are being investigated and trialed as antivirals for the treatment of COVID-19. Some of these medications are included on Admera Health's PGX1+ test. That is, those medications that have the highest level of clinical validity and clinical utility are included on our test. As I mentioned earlier, many of these drugs are still investigational and some are not approved by the FDA yet. Now that we've looked at the pathophysiology for COVID-19, now we're going to look at how the host immune response works after infection. So once the COVID-19 virus has infiltrated the alveoli, viral replication triggers a hyperinflammatory response. Once this response is triggered, there's an influx of activated neutrophils and inflammatory monocytes and macrophages. Th1 and Th17 are induced, and specific antibodies are produced. We're now going to look at medications that immunomodulate the host immune response. Again, these medications may or may not have been approved in the U.S. for conditions in the U.S., they are investigational for use in COVID-19. The first immunomodulator that we're going to look at is interleukin-1 receptor inhibitor, anakinra. The second is interleukin-6 receptor inhibitors. Next, we have leronlimab, which is a chemokine receptor antibody. And lastly, we have the Janus kinase 1 and 2 inhibitors. The net effect of each one of these classes is that they mitigate the human immune response to COVID-19 and the cytokine storm that results in COVID-19 and is thought to be the critical factor to poor outcomes in COVID-19. The last groups of immunomodulators include corticosteroids, such as budesonide, fluticasone, and triamcinolone. Another group of immunomodulators are the granulocyte macrophage colony stimulators. We also have complement inhibitors. And last but not least, drugs such as tacrolimus, which are T helper cell dependent B cell response inhibitors. These medications all are expected to help with COVID-19 by mitigating the human immune response and the cytokine storm that can result. So what are the pharmacogenetics related to these immunomodulators? You'll see those here in this chart. Having the pharmacogenetic data for these medications makes it possible to personalize immunomodulator therapy for your patients to mitigate the COVID-19 outcomes. As I mentioned before, we're now going to look at the acute clinical course the patient experiences post-COVID-19 infection. The three most common conditions reported for patients with COVID-19 infection who are hospitalized are acute respiratory distress syndrome, coagulopathies, and sepsis or septic shock. Needless to say, one or more of these conditions increases the patient's risk for poor outcomes. Any way that we can precisely manage these conditions, we may be able to decrease poor outcomes and improve the positive outcomes for COVID-19. This first group of medications that we're going to look at are considered adjunctive care in the treatment of acute respiratory distress syndrome. Because patients with acute respiratory distress syndrome are most often intubated, anesthesia inducers are needed to place the patient on ventilators. Anesthesia inducers include fentanyl, succinylcholine, midazolam, ketamine, and propofol. Additionally, patients with acute respiratory distress syndrome post-COVID-19 infection experience a fluid overload in their lungs. In fact, ARDS has often been termed drowning on dry land because of the fluid overload in the lungs. To mitigate the fluid overload, diuretics are prescribed to reduce the amount of fluid. Hydroxychlorothiazide, furosemide, and spironolactone are some of the medications that are used as diuretics in acute respiratory distress syndrome. And lastly, we have the inhaled vasodilating agents. These medications are indicated for primary pulmonary hypertension in the U.S. However, they are being investigated for use in treating acute respiratory distress syndrome secondary to COVID-19. I mentioned earlier that in addition to acute respiratory distress syndrome, patients with COVID-19 can also experience coagulopathies and sepsis. The adjunctive care used in these conditions include thrombolytics for coagulopathies and antiseptics, such as azithromycin. Here we have the pharmacogenetic gene-drug pairs associated with the medications that are used as adjunctive care in the treatment of patients with acute respiratory distress syndrome, coagulopathies, and sepsis post-COVID-19 infection. Having your patient's pharmacogenomic data at hand so that these medications can be precisely managed will lead to better COVID-19 outcomes. So now that we have talked about COVID-19 infection, we've talked about the host immune response, we've talked about the acute clinical course. Let's talk about the mental health consequences of COVID-19. Needless to say, patients who had mental health conditions prior to the COVID-19 pandemic may be experiencing flares in their condition, and patients who may have never experienced mental health conditions may be experiencing mental health issues for the first time. In particular, patients who survive COVID-19, who have been in the ICU for conditions such as acute respiratory distress syndrome, sepsis, and coagulopathies, often have a post-ICU syndrome that includes the mental health conditions of PTSD, anxiety, depression, and pain. These patients, having survived COVID-19, deserve to be able to take the correct medication the correct time, the first time. And in addition to patients who survive COVID-19, there are frontline healthcare workers and the general public who also could benefit from the pharmacogenomic data to precisely prescribe these psychiatric medications. Shown here are drugs and genes that are included on Admera Health PGX1+ test. This list is not a full list. In summary, pharmacogenomics medication therapy management before COVID-19 infection to properly and precisely mitigate Preexisting Conditions to prepare patients with chronic conditions for COVID-19 exposure, COVID-19 infection, and COVID-19 survival. In addition, pharmacogenomics-directed medication therapy management after a patient is infected with COVID-19 can positively mitigate the pathophysiology of COVID-19, the host immune response to COVID-19, the acute clinical course that results from COVID-19, and the mental health issues that may arise or be intensified by COVID-19. Thank you for joining us today. I have added references at the end of this presentation for your use in digging deeper into this material. This concludes my presentation, and I'd now like to open the floor for questions and comments.
Thank you, Dr. Winslow, for your informative presentation. We will now start the live Q&A portion of our webinar. Now, to our audience, if you have a question you would like to ask, please do so now. Just click on that Ask a Question box located on the far left of your screen, and we will answer as many of your questions as we have time for. Okay, let's get started. Wow, we have so many questions already coming in. Dr. Winslow, let's begin with this one. Many hospitals are reporting that venous thromboembolisms are contributing to COVID-19's high mortality rate. Can you elaborate on the medications being used to prevent and treat the coagulopathies and their pharmacogenomics?
Sure, that's a great question. So let's take a look. The data that has come out of China, the Netherlands, France, and the U.S. Is reporting that there's a high correlation between VTE and mortality rate for COVID-19. Currently, the ISTH is recommending that all patients that are hospitalized for COVID-19 who do not have any contraindications to prophylaxis be prescribed the standard prophylaxis that any patient that enters the hospital would be given if they were deemed critically ill and at risk for VTE. So those medications include, I'm going to move down to my slide deck. So the medications that are currently recommended by ISTH are the low molecular weight heparins and fondaparinux. Now, in addition to these two medications, if a patient progresses to an active VTE, ISTH is recommending body weight dosing, low molecular weight heparin or heparin. And for those medications, let's look for their pharmacogenomics. Okay, so these are the pharmacogenomics that are associated with heparin and the low molecular weight heparins on slide 36. Then on slide 37, I have the pharmacogenomics that are associated with the oral anticoagulants, which are the medications that are being recommended should the prescriber decide to transition the patient out of the hospital and for discharge. So warfarin and rivaroxaban are included on our PGX1+ test.
Thank you, Dr. Winslow. Now, As we've learned, remdesivir was granted emergency use approval by the FDA last week for treating COVID-19. Will Admera Health be adding remdesivir and its associated pharmacogenes to its PGX1 Plus test?
That's another great question. Admera chooses which medications to add to their test and which genes based on FDA guidelines. So medications that are included on the FDA biomarker table, and also medications that have pharmacogenomic indications in their FDA-approved drug labels. And we also include medications that have CPIC guidelines. So only when remdesivir is FDA approved and its pharmacogenomic biomarkers are identified by the FDA or CPIC would we add them to our test.
Thank you. Now, is chloroquine, which is included in the PGX1 reporting, the same medication chemically as hydroxychloroquine?
They are not the exact same chemical, but they work very similarly.
Now, Dr. Winslow, if an 80-year-old has already had a pharmacogenomics test well before COVID-19, what, if any, communication should be sent to that person regarding COVID-19?
Sure. I actually feel like that's an excellent opportunity to reach out to that patient and do a medication check. The most optimal place for pharmacogenomics is preemptive. So reaching out to that patient and doing a medication review to make sure that the patient hasn't discontinued medications or started new medications, just to make sure that those medications are optimized so that that patient can be at their best condition that they can achieve. So I think it's an excellent opportunity to make that check-in and review the medications with their pre-existing pharmacogenomics results.
Thank you, Dr. Winslow. Now we have time for a few more questions, but I do want to let our audience know that any questions we are unable to answer live today, and additionally, those questions that come in during the on-demand period, they will be addressed via the email address you provided at the time of registration. Okay, let's squeeze in a few more questions here. Dr. Winslow, are there medications such as chloroquine that should not be used in persons with G6PD deficiency?
Absolutely. And that's part of the concern that we're looking at, for example, with hydroxychloroquine and chloroquine that were approved for emergency use by the FDA. G6PD is mentioned in FDA drug labeling for those two medications, as well as other medications, even outside of COVID-19.
Dr. Winslow, is there enough time to get the results back, or is this on patients who have already had the test?
Well, the test results take about 7 to 10 business days after we receive the sample. Now, the best case scenario is for patients, especially those that have underlying chronic health conditions like the ones I mentioned in the presentation. The best case scenario is for them to have had a pharmacogenomics test before they experience a crisis or end up in the hospital being treated for COVID-19 or any other type acute situation. So depending on the length of stay in the hospital, yes, the results could be returned before the patient's discharged, but it's also important to consider that what's going to happen to the patient and what medications might be used to manage that patient post-hospitalization. So currently, we don't have enough long-term data to show what the long-term consequences for COVID-19 are going to be. So the test is just as valuable. The results are just as valuable for that patient post hospital stay also.
Dr. Winslow, do diabetic patients also have increased risk of infection and or disease severity?
Absolutely. Absolutely. As a matter of fact, the number one chronic condition that predisposes patients, according to the CDC, for COVID-19 infection is obesity. And obesity is quite commonly related to type 2 diabetes. So absolutely, and as the diabetes is actually the second highest underlying condition for patients that have poor outcomes.
Now, we see too many useful drugs, but how do we decide which ones are the best ones and with the lowest side effects?
Sure. It would be great to say that a pharmacogenomics test was a perfect map for how to prescribe, but in reality, pharmacogenomics is a tool in the precision medicine toolbox. So in addition to clinical factors that go into choosing medications for a patient, pharmacogenomics can help with that process to help choose those medications that will be more efficacious for the patient and have less toxicity.
Thank you. And we have time for a few more questions. How much burden do you see due to different ethnicity of the patients?
Based on the data that has been reported thus far from hospitalized patients with COVID-19, whites are proportionately having more cases of infection and being hospitalized. Next would be African Americans and then Hispanics. It is important, though, to point out that these are hospitalized patients, the numbers that we have from the CDC. So what's actually happening in the community for patients that either didn't seek health care or they sought health care and they weren't considered to need hospitalization, the numbers may be different when you look at the inclusion of patients that are not hospitalized with patients that are hospitalized.
Thank you. Now, Dr. Winslow, we have found that the breakdown of the medications and specific genes to be very helpful. My question is, how do you see the outlook on the significance of pharmacogenomic testing implementation changing post-COVID?
My hope is that because COVID-19 is so personal, we don't know all of we don't know everything we need to know about COVID-19, and we need medications to treat it and prevent it. So my hope is that this scenario has taught us the need to look for the pharmacogenomic basis, how to treat and how to prevent diseases.
Thank you, Dr. Winslow. And we'll wrap with this final question. How can someone be able to receive a pharmacogenomics test if they're interested?
Oh, absolutely. So for anyone that's interested in receiving a pharmacogenomics test from Admera Health, or if you're interested in ordering a pharmacogenomics test, I have here on slide 33, I have pulled up our address, our telephone number, and I have our website. And if you go to the website, you'll find that we now have online ordering for your pharmacogenomics test. So patients can go to our website now and they can request a test. And secondly, providers can now go to our website and they can order tests for patients and have those shipped to the patient. So we've made it, we've tried to make this situation very easy for people so that they can obtain a test.
Thank you, Dr. Winslow. And do you have any final comments for our audience?
I'd just like to thank you guys for hosting me, and I'd like to encourage anyone that has any questions, any further questions, to email me. I'll be happy to answer those questions for you, and glad to be here. Thanks for joining.
And thank you, Dr. Winslow. And before we go, I would also like to thank our audience for joining us and for their interesting questions. We had so many questions we are unable to answer live. So just as a reminder, those questions, and again, those questions that are submitted during the on-demand period, they will be addressed by Dr. Winslow via the contact information you provided at the time of registration. I'd like to once again thank Dr. Becky Winslow for her time today and her important research. We'd also like to thank LabRoots and our sponsor, Admera Health, for underwriting today's educational webcast. Today's webcast can be viewed on demand, and LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. That's all for now. We thank you for joining us. Stay healthy and have a great day.